Hi, and welcome everybody to our afternoon webinar. This is the first time we're actually doing an afternoon webinar, so I'm very happy you could join. But today we will present a very special speaker, Lena Meyer-Hein, live from Heidelberg, Germany. And first I would like to thank Bracco for sponsoring our webinar series. And I will tell you something about Lena Meyer-Hein. She received her diploma in 2005 and a doctoral degree with distinction in 2009 from the Karlsruhe Institute of Technology. She conducted her postdoctoral at the German Cancer Research Center at Heidelberg and the Hamlin Center for Robotic Surgery at Imperial College London. Right now she is DKFZ division head in Heidelberg, and she's now working in the field of biomedical image analysis with a specific focus on surgical data science, computational biophotonics, and validation of machine learning algorithms. And that last topic is where I mostly know her from, because I've been closely following her lectures at our major conferences. And she's a very gifted speaker, and I really enjoy her lectures especially about the metrics, because that's also one of my favorite topics. My name is Meryl Heisman. I'm currently USOMI board member and Young Club chair and a final year resident in radiology in UMC Utrecht, the Netherlands. My co-panelist today will be Pinar Yilmaz. She's currently a postdoctoral, actually a research fellow in Boston, remotely obviously, and we will host this webinar together. So the webinar will, the topic of the webinar will be why we need transdisciplinary collaboration to really solve clinical problems with machine learning. And this is important because due to the publicly available data sets and domain knowledge and close collaboration is no longer essential. And this can actually lead to potentially severe consequences of, for example, non-reproducibility. And therefore, it's extremely important that we highlight the importance of domain knowledge for various steps within the development process of algorithms, from selection of the training and test data to the presence of possible confounders to the choice of appropriate validation metrics and the interpretation of the results. So Pinar, please explain now how the viewers can use the Q&A box.
Dear attendees, welcome. So in case of questions, please type them in the Q&A box and we will discuss them at the end of our webinar together with the speaker. So now I will give the floor to Lena. Lena, the floor is yours.
Yeah, now you should be able to see my screen. Maybe you can give me a thumbs up. Or something.
Yes,
yeah.
you can.
Many thanks for this very kind introduction, and also thanks for inviting me here. It seems like my talks have a little bit accumulated in the past month, so I hope you haven't seen one of my recent talks. I always try to put in something new, but I cannot reinvent everything within a month. So this is the topic. Meryl introduced it really nicely. I'm a surgical data scientist, but I think a lot of this actually also applies to radiological data science. But you will see some bloody pictures in this talk. Sorry about this if you're not used to it. So as you know, challenges are the state of the art to benchmark AI algorithms. ImageNet would be a very prominent example from the general machine learning field. In the field of surgery, we have, for example, the endoscopic vision challenge, which we have been conducting for many years. And I still remember in 2015, this researcher popping up. He was not traditionally in our community of endoscopic vision. He came, he presented his method for one of our challenges and ended with the slide that you see here. So he had already won a few challenges at MICAI in various different fields, actually. He also won one of ours. And yeah, that sort of triggered my thinking about whether or not we actually still need domain knowledge to solve our problems now that we have deep learning as such a powerful generic method. And the short answer is yes. I think we actually need domain knowledge in a lot of steps in the process. And today I want to talk about a little bit about why I think this is the case. A prominent example, I think, from recently is COVID-19 research. I think people also outside the medical domain started working on COVID-19 data. And I really like this paper here where the authors showed that people started merging two very prominent data sets. I think it's a yellow and blue one from COVID-19 patients, adults, and one from pneumonia patients, actually all children. So this means if you just take these two data sets without looking behind the scenes, then you will easily get 100% accuracy because you have to just distinguish children from adults. And this is a very prominent example for a confounder, and I will come back to this later. So very briefly, I'm from the German Cancer Research Center. It's located in Heidelberg, which is quite famous for its old town. We also used to leverage the old town and the nice bridge for our lab bridge parties. Unfortunately, this is not possible currently, but hopefully we will get back to this very soon. So as I mentioned, I'm a surgical data scientist. So I'm doing biomedical image analysis in the specific context of medical interventions. If you're interested in the topic, I would like to point you to this overview paper that I'm citing here. Now let's get into the actual topic. I will look at two specific aspects. One is challenges in general, and one is a European Research Council grant that I recently acquired, simply because I'm so excited about it. But all of this, what I'm talking about, will be about the relevance of domain knowledge. So let's start with the data set. Many thanks to my clinical collaborators, the technical collaborators, and also the members from my team. And now a bloody picture for you. So this is what a surgeon would see during an intervention, and you see that you don't really see much, because what you want to see is either hidden underneath the visible surface, or it shows very poor contrast. So the traditional approach, and I'm just providing this to you for some context information so you can follow what I say afterwards. So the traditional approach here would be to do data fusion. But data fusion has some problems. For example, you cannot account for tissue dynamics, perfusion dynamics, for example. So what we propose is this. We propose, when we do video imaging of the internal anatomy, we propose going beyond the visible spectrum of light, so beyond the classical RGB, red, green, blue imaging, which has been inspired by human perception. And we just acquire a whole range of images at different wavelengths. So why would we do this? Very briefly, if you look at the molecules in tissue, then you note that they absorb light very differently. So you see these spectral fingerprints here in this image. Now, for example, if you look into the visible spectrum, because we work with log scale here, this means that mainly hemoglobin and hemoglobin bound to oxygen are the most notable absorbers. Then you can basically recover tissue oxygenation by taking such multispectral measurements. So I don't really want to go into the details of the method right now, but I want to show you what we can do with it. And then, of course, talk about the problems. So here you see actually a patient that we treated last month. So what we do here, we basically analyze the data, the multispectral data that we get in real time to compute something like an ischemia index, that's AI-based index for whether or not the organ is well perfused or not. So in all my previous talks, I mainly talked about this general topic of regression, quantifying tissue parameters. But today I want to talk a little bit more about classification. And I will take sepsis as an example. So if you remember these spectral fingerprints, now we look into the near infrared window, and you see that there water is actually becoming a notable absorber of light. We're basically working on concepts to quantify the water concentration live. So why is this important for sepsis? It's because we know that edema can occur when you have a sepsis, and the hypothesis was that the water content may actually increase. And now finally to the problems, because I think overall in all these scientific talks, we talk far too little about actual problems that occur. So Silvia, my PhD student, actually got data from the clinicians, and she obtained an accuracy above 97%. And I mean, this would naturally be a Nature paper, probably, because sepsis is a very severe condition. If you manage to diagnose it, to detect it with such an easy low-cost device, that would be quite breakthrough. But then, I mean, she showed us her data, and we thought, okay, this is almost too good to be true, because, I mean, getting an accuracy above 97% from scratch is probably not realistic. So yeah, we started basically digging into the raw data. And now if you think this may not be a relevant topic for you, I want to point you to this really nice paper in Nature Digital Medicine 2019 in the context of radiological data science. So here, the paper is basically about hip fracture detection. And the authors identified a list of confounders that you see here. For example, the scanner with which the data was acquired, the age, the body mass index, etc. And first of all, they showed that using the imaging data that they have, they can actually quantify these confounders. So they can classify or regress them. And if they can do this, then of course, these confounders can also be used for the target task. And they showed that this is actually the case. And I find this quite astonishing. So when they took the data as it was, cross-sectional data, they obtained an area under curve of 0.8 something. I think, yeah, the upper curve here. But then if they match all the confounders, so in the group with and without hip fracture, they would do a matching between age, body mass index, scanner model, etc. They basically obtained a classifier that was no better than chance. And I think that's a pretty breakthrough result in this case. And it shows how careful we need to be with respect to confounders. So in our specific problem, I mean, we got the data from the clinicians, and then we took a very careful look at them. And one thing that we observed, and I'm mentioning this not because this application is relevant for you, but because I want to show that you really need to dig into the raw data to see such confounders. So we observed, for example, that the patients had a very different pose of the hand compared to the healthy volunteers. Now, in theory, I mean, the neural networks can see a lot that even we don't observe. So now we acquire from the palms of the hands, we acquire this high dimensional spectral data, no longer human interpretable because there's so many bands. So actually the network could, in theory, just overfit to the hand poses in some way. So maybe the hand poses have an influence on the measurements. Another issue that we found, I wasn't aware of, that actually the data was taken sequentially. So my understanding had been that this was parallel, but it wasn't the case. It was sequential acquisitions, and there may be, for example, a summer-winter effect. So yeah, we identified quite a few confounders. If you're interested, have a look at this paper. But I mean, it's a general insight. I think you should think about, if you work on classification, what these confounders may be. On the positive side, also leveraging our prior knowledge, it's not only that we were able to classify the data, but also when we try to regress the actual water content, then the sepsis patient compared to, for example, post-operative pancreas patients actually had a higher water content, which is exactly what we would expect. So this this was basically a confirming result. But now we have to go into, basically we have to reacquire all the data in a careful setup. And yeah, this again supports my personal hypothesis that we have to work much more closely together. So the clinicians and us, I think very early on, even before a data acquisition, we have to talk such that such things don't happen, basically. Yeah, second example, and I think this was for me even more astonishing, and I think this could be the case in many other studies as well. So another application for classification using spectral imaging data is this tissue differentiation. And we recently found, well, basically we have a huge data set of spectra. So this is how our measurements look like. This is basically pixel-wise the data that we acquire. And yeah, like I said, we analyzed the raw data very, very carefully. And what we found at some point was that when we split the data temporarily, we get this result. And we found that at a specific time point, there must have been some change. And we found out that the camera provider actually visited Heidelberg that day. And there must have been some change that we were not even informed about, which is severe because now if we don't have the balanced classes in these two groups, camera 1 and 2, basically, then this can act as a confounder. So basically you have the prior knowledge that for a certain camera type, some classes occur more or less often. And then again, you overestimate basically the performance of your algorithm. So what can you do? Well, one thing that we've been doing for a long time now is to collaborate very closely with statisticians, Annette Kopp-Schneider and her group actually in our institute, and that's been great. So one of the things that we do a lot is to work with mixed models. So what you see here, in fact, is an explanation plotted over the wavelength. So the x-axis is the wavelength. You see how much of the variance in the data is explained either by the organs that we want to differentiate. So this would be desired. So ideally, we would have 100% here. Then we have effects stemming from the individual, and then some residual, some noise or unexplained variance. And yeah, this was a very, very encouraging result here, because most of the variance is actually explained by what we want it to be explained by. But now we're basically running the analysis also for all the confounders that we're identifying to see what really influences the spectra the most. Yeah, so what else can we do besides quantifying effects? Something that we're working on is to basically learn a representation of the data. I call this Z here, in which the information corresponding to different aspects of the data corresponds to different regions. So if you're interested, maybe read, for example, the DIVA paper by Max Welling. We were inspired by this. So, so in this case, basically, we have 3 subspaces of our latent space, the representation that is used in our neural networks, and we want to decouple the information that is important to characterize the tissue from that is important to decide whose data was taken. And it's unpublished work, but making a long story short, the disentanglement works quite well. So you see that if we color code the individual, then this clusters nicely in the subspace in which we want to encode in the patient individual characteristics, vice versa, in the subspace relevant for the actual information, the organs cluster nicely, and which is exactly what we want to see. So this is the line of research that we're currently pursuing. Yeah, second aspect, annotations. we talked a little bit about the actual data, but of course, annotations are equally important. Thanks also again to my collaborators at this point, also international collaborators as part of the Bias Initiative and the MICA Challenge Working Group. So yeah, how to label. This is an example of 3 different experts labeling the liver very differently because they take different conventions for whether or not to include the vena cava. Now you may say this is a very special case with the liver, but I don't think that's true. I actually think that even very simple tasks can have quite complicated labeling instructions in the end. And I want to show you one example from my field, surgery. So you would probably say, okay, labeling surgical instruments is quite straightforward. You just mark the artificial objects. But if you look at this, we decided, for example, to always label the foreground object. So yellow closer to the camera than green. So green is basically interrupted in this case. Now, what do you do in case of transparent objects? Do you label them? Do you not label them? What do you do if you have an overlay? I mean, here I would say we would need to speculate where the instrument is, so we just exclude the label. But then what do you do if it's just a written text? Then it becomes infeasible to segment out all the different letters. And what I'm really trying to show here is that the devil is in the detail. And my personal opinion is that you really need to be careful to generate good labeling instructions. So we wanted to quantify, and this is actually a new result. So we wanted to quantify the effect of labeling instructions. So we asked for professional companies. Those companies also have access to domain experts, and Amazon Mechanical Turk, an open crowdsourcing platform to label our data. And we gave different levels of labeling instructions. And long story short, it turned out 1 is basically perfect performance, 0 is worst case performance. It turned out that this really made a huge impact, how we instructed the laborers. Maybe taking one little step back with respect to the labeling, and I guess I'm not sure if it perfectly fits the storyline. I just want to talk about something new, and this is a recent MICA paper that was just accepted. So we spent quite a bit of time addressing data sparsity in biometric image analysis. And one thing that I was always wondering was why do we focus so much on solving tasks individually? And this became so clear to me when I watched my son, at this time he was 1 year old, getting this new book. And we explained him where to press the button. It's a silver button. And he did it, I showed him twice and then he could do it. And I mean, he didn't need 1,000 examples, right? He needed 2. And this is because he also already has this conceptual understanding of the world somehow. He has learned related tasks. And at that point, I think it was 3 years ago, I decided that I wanted to work on this. So I employed Patrick as a PhD student after getting some funding, and we started working on this. So what we do now is and I will not go into the details, but you can have a look at the paper. We take a task. It can be a medical imaging task. It can even be a task from another domain. And we convert the data, including the labels, into a fixed length vector representation. Now, this means that now we can represent all the tasks that we've ever learned in one common coordinate system. So you see it projected on 2 axes here, basically. And yes, then we can leverage this knowledge, and I will not go into detail, for meta learning or for, in the simplest case, pre-training on previous tasks. So overall, I think we really need to go more towards such a direction of research. yeah, that will be the meta learning. And then finally, and this is the last piece that I'm also covering in this talk, I briefly started talking about it earlier. It's the learning from simulations. So if you remember the first video that I showed you, where basically we had this AI-based ischemia index, we train our methods based on simulated data, because we want to get rid of the hen-egg problem that we're developing an imaging method to solve a problem, for example, to resolve oxygenation in real time, but we don't have a reference imaging method to generate our training data. So the solution that we have, and we've been working on this for more than 5 or 6 years now, is to leverage synthetic data. So you see here, that's also a simulation. When we change the tissue oxygenation in 1 pixel, you already see that the measurement changes. So what we did is we basically produced or used all our prior knowledge to generate such synthetic data. I've given plenty of talks of this, so I don't want to spend too much time on this today. And now we want to go one step further, because previously what we did mainly was to detect relative changes. And now we want to go, and this is what is funded by the ERC now, towards quantification. So for this, we basically consider image formation, so basically going from the tissue properties to the measurements, and decoding, taking measurements, going back, quantifying what we see as in one joint framework. And previously we used our prior knowledge to generate synthetic data in order to enable AI to have training data. And now we go one step further, because we also leverage real data to improve our domain knowledge, to improve our understanding of the world. So we basically see whether the data that we have matches the domain knowledge that we have. So let me make this a bit more concrete. This is just an explanation of the imaging method that we actually apply. So if you remember, I basically talked about spectral imaging before as a generalization of standard video imaging. And now we take this to tomographic imaging. So then it's basically, imagine something like an ultrasound system, which gives you complementary information to ultrasound. So let me explain. This is a logo of the DKFZ in a milk bath, basically. Now, if you go to gynecology, use a 3D ultrasound system, you would basically see the sponge and the sign, but not what is written on the text. Now, if we illuminate the tissue with laser light, the molecules, again, this is the same fingerprint graphic I showed you before. So the molecules absorb the light depending on which molecule it is, basically. And then the tissue expands due to the absorption of the photons, and the heating up and the expansion leads to an ultrasound signal that we can then measure. So light in, sound out. And then with this, we can then basically measure the optical properties. So in this case, it's a single wavelength image. We just want to visualize the texture, but everything that I explained to you before now also works in principle tomographically. So you see it here illustrated. You also see that there's still quite a difference in terms of image quality, resolution, but this is basically where we stand. So coming back to where I started, we want to quantify tissue parameters, water, oxygenation, and this whole framework naturally integrates both AI and domain knowledge, because again, we use domain knowledge to go from these so-called parameter images to the image. So we use all the domain knowledge that we can get to generate synthetic data. So the question is, how do we improve our simulations by AI? We're just getting started, but I want to give you a little pitch based on the archive paper that we released. So basically, what you see here is the underlying properties that we use for a Monte Carlo simulation. So we have assumption about tissue geometry, about acoustic properties, speed of sound in the tissue, for example, the optical properties, scattering, absorption properties, and then we can run Monte Carlo simulations to actually generate images, and we can quantify the difference between real and synthetic images. So from these three components, the geometric tissues, the properties, the optical tissue properties, and the acoustic properties, I want to look at the geometric properties for now, because I think this is something that will generalize potentially to other fields. So what we do briefly is we extract underlying tissue geometry from some modality. It could be any modality. In this case, it's really ultrasound and photoacoustics. And we have a very simple setting because it's early work. So we're looking at forearm images. And then this gives us basically semantic segmentation maps. And then we use a GAN, generative adversarial network, to learn to generate such semantic segmentation maps. And the trick here is that we would not be able to easily use a GAN for generating the whole spectral images, because there's physics constraints that are not easy to handle. So we decoupled, we disentangled the various factors, and we said, okay, let's just start from a semantic segmentation maps, and then we can use our prior knowledge to assign physical properties, optical properties, acoustic properties. And long story short, when we compare the data, we actually found quite a gain in accuracy. Our downstream task, which was the semantic image annotation. But again, it's early work, but very encouraging. Metrics. Meryl already mentioned this as one of her favorite topics, and I agree. It's a really important topic. In our earlier work, we analyzed more than 500 competitions, actually. Oh, I see a bug here. This shouldn't be here. So 500 competitions. And we found the dissimilarity coefficient to be the most widely used metric, actually. You see it here, given a blue or purple reference contour, that would be the expert annotation, and the prediction of the algorithm, orange, you basically compute a value between 0 and 1, 1 meaning perfect overlap. So this makes sense at first sight, but there's so many pitfalls. So for example, if you have a very small structure, like in this case here, then you see that a single pixel difference can make a huge impact on performance, right? And then if it would aggregate over multiple structures, you see that you would put a huge weight actually on such single pixel differences. And I think this becomes even more absurd, basically, if you consider the inter-rater variability. I really like this paper by Leo Joskovic, which really shows that inter-rater variability can be extremely high. And also, not to forget, the variability of the neural networks. So I think it's not so widely known that neural networks are not actually deterministic. And this is not only because you work with, for example, random seeds, but it's also because of the order in which computations are performed on the GPU. I mean, have a look at this paper if you're interested. But long story short, neural networks as applied now are not deterministic and could easily result in single pixel differences. Classification, similar thing. I mean, I think what I show here is a very common problem, also well-known problem, I would say. Class imbalance can have a huge effect on accuracy. So here, I guess we would not like prediction 2, which would always predict the same class actually, but you wouldn't see this with the accuracy metric applied. And it gets even worse. So I just was, my attention was brought to this recent paper here. And they provide an example where a sensitivity of 99.7% was reported, which is great. But then they also calculated, they used the raw data, a precision of 0.33, and this was not reported. So you see, there's some flaws, I guess, in the way methods are validated. So if you're interested, have a look into this archive paper that we put online. We decided to make it a dynamic paper. Currently, it focuses on segmentation problems, but we will extend it to, gradually to all the different problems that we have in biomedical image analysis. And if you're interested to contribute, just send me an email. So what do we do about this besides increasing awareness? Well, we have formed an international consortium. This originated from the MICAI Society, MONAI, and BIAS initiative, in which we now give concrete best practice recommendations on how to align the metrics used for validation to the actual underlying clinical problem. So let me check. I have 5 more minutes. So, well, maybe which topic do I choose? Well, I'll just go through this. So challenge ranking, I do this quickly. As you know, challenges are the way to assess AI algorithms. They come with a lot of fame, and our research really started with the question whether the winner is really the best. And I like to illustrate, and this was actually with many institutes involved, and I like illustrating this with a sample challenge, a very popular challenge actually. You see the best ranked algorithms here, that now you can play around with many parameters, the metric to use, the aggregation operator, and also the order in which you aggregate. So do you first compute a rank per image and then aggregate, or do you first aggregate and then compute a rank? Do you use the mean or the median? So some design choices to make, and it turns out that they have a radical influence actually potentially on the ranking. So what we did is we provided an open source tool. I'm rushing a little bit now, but this shows you 2 different synthetic challenge results and how they result despite the very different raw data in the same ranking. And what our tool does, it actually accounts for such uncertainties and makes sure that you are aware of the robustness of the ranking that you get. So left-hand side would be a very robust ranking, whereas right-hand side suggests a not so robust ranking. A last point I want to make is, and I think this is also very important actually, how do we learn from our challenges or from validation studies in general? And I think currently we learn very little. So we learn who is presumably the best, and we learn something, I would say, about average performance. But what do we learn about the actual problem? I mean, what is working? What is not working? And typically what we do is we would do a manual analysis. So we cherry pick maybe some examples here, again, medical instrument segmentation as application. We cherry pick, and we maybe more or less guess what would be the characteristics in which algorithms perform particularly poorly. So what we propose instead, we just submitted this paper, is to work with mixed models and to do a meta annotation of the images before, such that you can really quantify what affects performance the most and then tailor the new developments to the actual problems. So I don't have time anymore to explain this in detail, but briefly, you take your data you model the image characteristics as fixed effects. So in our particular case, we would talk about aspects like is there a lot of bleeding in the image? Are there motion artifacts? Is there under or overexposure? And then you also have to take, and this is often neglected, account for the hierarchical data structure. So, for example, if you have multiple images from the same hospital, this can be an important effect that needs to be considered in the statistics. And long story short, what you then get, and I will not go over this, is something like this, where you clearly see which are the effects that are important. And in this case, surprisingly, we found that an overexposed instrument, for example, has a very positive effect. And this is in contrast to what the community sometimes says, that overexposure is a problem. It's actually beneficial because then the instrument is light and can be segmented more easily. Last but not least, last slide, basically, what we're working on now is the more technical view on what I just said. So now we looked at what are the clinical parameters that matter, but I think an equally important question is, I mean, why is the winner the best? What makes the winner the best? And if you look at this ranking shown here, it's actually a first place up to place 100 of a recent challenge. You see, it's not the architecture, because almost everybody used the 3D unit, for example, in this case. You cannot see this from the information that is typically reported in the paper. And we're addressing this issue now in our current work. Hopefully I can report about it in about a year. I find it a very exciting research topic. And for you as a take-home message, I think the fact that the methods, the fact that the methods we don't really perform at the front lines of clinical practice can be attributed partly to the way that we validate. We don't validate properly yet, I think, and we have to incorporate more domain knowledge to do this right. Thank you very much.
Well, thank you so much, Professor Meyerheijn, for your excellent talk. Really a lot of information to take in. But the good news is this will be available on YouTube, so you can all rewatch it. And also, thanks for recommending all those papers. Well, we still have quite some time actually for the discussion. So as I understand it correctly, what you've meanwhile, while we speak, you can just type a question in the chat box, you guys. Now is your chance to pose a question to the great Professor Lena Meyerheijn. So if I understand it correctly, the inconvenient truth is actually the overfitting problem. But the ways to handle this are incorporating domain knowledge, also meta learn from data you can or you accrue or you create, and then also be aware of the pitfalls of the metrics. Is this correct?
Yeah, I mean, roughly, yes. So I mean, I think roughly you need domain knowledge in the whole process, right?
Yes.
And I was trying to say, or to bring across that this is the case. So it starts already with the data acquisition. So can you be sure that whatever device you use, that there's no confounder that you're not even aware of, like the example that I showed from our camera. Maybe there was some changes. So especially when you work with classification, can you really be sure there's nothing like this? Annotations, of course, can be very biased. Metrics, like you say, require a lot of domain knowledge such that they match what we actually want to measure. And then, yeah, I mean, what problems do we actually still have? Is the problem solved? Is it not solved? What accuracy do we actually need? And I think there's so much that requires domain knowledge, and it really requires us to work very closely together.
Yeah, so the doctors are also always needed. So that's good to hear. We happily participate in projects like this. I think, Pinar, we do have some questions coming in.
Yes, we have some questions coming in. The first one is from Kevin Grootlipman, and he says, thank you for your talk. Do you think we should evaluate metrics like DICE compared to the inter-reader variability of radiologists, for example? So what's the DICE between radiologists? And I have also a question after this one related.
Yeah, very good question. So first of all, I think, yes, whenever we have enough capacities, we should know what inter-rater variability we have. Also, because it almost gives us an upper bound of the performance that we can achieve, right? So if you take, say, 2 radiologists and one time use one as the algorithm and one as the expert, and then you achieve a DICE of 0.9, how can you expect your algorithm to achieve 0.99, right? So I think this is one thing. And then what you said is actually very, very interesting. So there's a metric called NSD, a relatively new metric that does exactly what you suggest, Kevin. So it basically looks at inter-rater variability, and it looks at boundaries, and it basically doesn't count an error if it's within a certain confidence interval, very roughly explained. But please look at NSD. Among others, it's, I think, explained on the medical segmentation decathlon side. I think there should be a link to it.
Thank you, Elena. So regarding to this question, would you suggest to have a few standard metrics mentioned per report in that we should, especially since you gave that example in which they give this nice sensitivity, but in the end, the accuracy is very low. So maybe that also for the journals, that they are very aware of which kind of metrics a report should involve, so that we could validate it properly amongst all of the studies that come in or research that has been done.
Yes, so I think so. This is exactly what I think. But now that we're trying it, and again, I'm talking on behalf of a large consortium, many experts involved, I also see how hard it is.
Yes.
Because it depends on so many factors. So and also there's let's say different philosophies. So I see 2 groups in our consortium. So one always argue from the clinical application, which is totally valid, but some also say, okay, but you know, the whole community, for example, uses DICE, so we need it regardless of anything else as a default metric for comparability. And DICE measures essentially overlap of segmentations, which is a technical perspective of the problem. So we have these 2 groups, and we see it's very hard to come up with concrete recommendations. So what we did in the process, and I'm happy to get more input and suggestions on how to do it better. So we started collecting problems, first of all. Mm-hmm. And then we started basically, so one part of the problem is that you don't choose the right tasks to begin with. So say you actually want to detect something, then why do you choose a segmentation metric if the contour don't even matter? If we talk about lesions in the brain, 2 pixels, you don't need a segmentation metric, you need a detection metric. So first, and this is the easier one, and we converged on this one after a few months. So first is to choose your task right. Do you have a segmentation problem? Do you have a detection problem, a multi-instance segmentation problem, etc.? So this one is okay. And now for the next part gets a bit tricky. So what we did is we identified pitfalls and we tried to characterize them. So what are the properties of your problem? So for example, what is the size of your structures relative to the grid size? Is the contour relevant at all or not? You know, there's clinical applications in which it can be really relevant to have the right contour. Think of tumors, but there's other applications in which it's not so important. So is the contour relevant? Then also how important is, for example, memory consumption or speed? And there's so many aspects that we're gathering now, and we try to basically come up with a process or something like almost a matrix is not the right word, but
maybe guidelines for
to say, okay, if you have this, don't use, for example, this metric. And then we come up with typical scenarios that you have. For example, given a radiological image, you want to segment a relatively large structure, etc., etc. Then we basically give sample recommendations on which metrics could be suitable. But yeah, going through this process, we observe it.
I can imagine that it's very hard because it also really depends on the question that is being answered, I guess, in the study that you're looking into, and then the technical aspects that are being used are also what you say within the algorithms. Certain steps are the same, but mostly they are not the same, and that makes it well difficult to I guess compare them with the same metrics as well. So we have another question in which Mehmet Bilgin SR asks, which test do you offer for small lesions? No dice, I understand.
Well, I mean, we haven't converged on everything, so it's just me now. But normally, I think for small structures, you typically talk about detection. So this is what you have to know first, and then a detection metric is often the best choice. But hopefully, we will be very clear on all of this in a couple of months. Yeah.
Then following up, there's another question, Fukangya, if I pronounce your name correctly. I wanted to know the imaging depth on photoacoustic imaging on the logo.
Of the image I provided, oh, that's a good question, but I can answer maybe more generically. So the imaging depth depends on the properties of the tissue. So in such a milk bath, it's quite easy to go several centimeters of depth. But in a structure like the liver, for example, which is really highly perfused, you don't get very far because you have to ensure that the light arrives at where you want to measure it. And just as a background, maybe for everyone, so ultrasound is a light in, sound out method, right? So you measure time of flight, and this doesn't work with light normally in high depth because of the scattering. So I always like that laser pointer example. If you put a laser pointer on your finger, you don't see a point on the other side, you see just red. And this is because the light scatters so much. So you cannot measure time of flight. But here you leverage the fact that you only have to bring the photons to your target structure. It doesn't matter how they get there, basically. And then you measure as the out signal, the ultrasound signal. So practically, I mean, I've seen reports of up to, say, 7 centimeters depth. With our system, it's more like in 2 to 3 centimeters, what we can do currently.
Okay, thank you. I think Kevin has another question, and you may partly have answered that. Do you think authors should explain why they use certain metrics and defend them with arguments for clinical usefulness?
Yes.
I think every author should be able to explain why certain metrics should be used.
Totally.
Yeah, I mean, for challenges, we actually put forth a bias statement. It's an equator guideline now, and it has exactly that parameter in there. So why do you use this metric? How does it match your goal? And the same, I think, holds true for validation studies. Yeah, very good point.
Great.
Thank you.
Well, otherwise, I still have a question. So right now, at least for radiology, there's many papers, and we don't have enough reviewers from the clinical side to also understand. And also understand AI. So you're advocating, at least in a sense, you don't need to understand it entirely, but you just need to be able to understand the general structure of a development study or validation study, and then check if the results are sound a bit, or if the claim is more or less correct scientifically. For this, you would need a basic understanding of the metrics. So what would you recommend for radiologists like myself? Where can you start without like investing a lot of time we don't have?
Yeah, that's an interesting question. Building up expertise. Yeah, I guess
Because for us, it's kind of hard. Like these papers are, for most people, I think, quite difficult without a specific background. And we are trained, of course, in some research things as clinicians, but
yeah, it's a really good point. I mean, generally, I think we should also have interdisciplinary teams of reviewers. Actually,
definitely.
So,
and there are. But how can you equip yourself as a research doctor, let's say, that also does research? Now with the sudden burst of AI studies, how can you familiarize yourself? For example, me, I have a biostatistical background, but there's some very important differences. And I've been struggling to, to get a grasp, and you can just do courses on Coursera, etc. But is there something you would recommend for people that don't have this much dedicated time?
It's a really good question. Maybe we need to put we need to write a paper on it.
Yes.
No, really, like a guideline for, I don't know, maybe not reviewing, but the most substantial aspects. I mean,
Yes.
common problem is that I see all the time is the overfitting on the test data.
Yes.
This is an example, right? I mean, people know they should test on different data compared to what they trained on, but I think a lot of people don't understand the consequences of having just one test set is basically not enough, because if you have just one test set, you basically already have a bias, because you check whether your method works, and then only if it's nice, then you submit it. This is already a bias.
Exactly. Right? You have to be really, it's quite time consuming. Sometimes when I review paper, I calculate, for example, specificity. And then it's really low, as you also pointed, like 0.33. But I do that because I know how to. And then you write, okay, great, it's high sensitivity, but then specificity is below 50%. So it's basically worse than a dice. Yeah. So.
No, yeah, you're right. I mean, I think the metric part, we will probably cover, or we aim to cover actually to some extent. So this could be a good guideline for this aspect, but I guess we need more. We need to cover more.
Maybe a pitfalls paper.
The whole chain, basically, the chain you need to cover. Yeah. How can we clinicians get a basic understanding, so that also when a company comes to us with their product, we pose the right questions, etc. Because these are difficult concepts for most people. Yeah, very true. Including myself. So yeah.
No, I think the most dangerous thing is, from my perception, that earlier in the days, before deep learning hype, in order to achieve good performance, you really needed to do a good job. So the fact that you achieved good performance was almost a proof that you did things quite well. And I think now it's almost the opposite, because I think if you do things, the more things you do wrong, the better the results are, because you overfit on the test set, or you don't take care of confounders, you ignore properties of metrics, and then the result is actually overperformance of the specific data set that you have. Of course not. Of course it doesn't generalize, but yeah, it's a good idea. We should write a paper.
Definitely. Okay, we have another question coming in from Stefan Vogler. How would you tune data collection efforts if you have found confounding factors in a first version of the AI algorithm? Simply collect more data and hope that it improves, or do a smaller but targeted data hunts? Only the data that is still missing. Okay, well, I sense a selection bias issue coming here, but
yeah, it's a really tricky question. I mean, currently we're actually doing a new prospective study, but this cannot be the only strategy at hand. So, I mean, one method's approach is to once you know your confounders, to develop networks that in their latent representation, you cannot see the confounders anymore. So so that would be a methods approach. But apart from this, I don't have a how do you say belastbar of English, bulletproof answer yet. It's a very, very tricky problem, I think.
Well, I would suggest, if I may suggest something. We still have 1 minute though. That's true. So we cannot answer any more questions. That do a targeted data hunt can be tricky because then it's not a random sample, and then you validate certain assumptions. But yeah, it can be done, I think, under certain circumstances.
I had one question with the mixed models though, because in that case, when you use the mixed models, does it handle the missing data? Because normally a mixed model does handle with the missing data.
I'm not sure what you mean by missing data, but
so you would have certain parameters that you include in your mixed models, but you won't have you don't need to have all the data because the mixed model itself handles missing data. But I'm not sure if it's the same for machine learning or algorithms as well, because I know for normal, if you use it normally, it does.
I mean, I have to admit, I'm not the mixed models expert. I always give this to my statistician experts, but I know that in general, the models are quite powerful. That's what I can say. It depends on which data you're missing, if it's the metadata annotations, but I think maybe I'm not the best person to answer this, and we probably have running out of time.
Yeah, true. It's 3
we
o'clock.
are. Yeah, actually, ladies, we have to close. So first, I would like to thank Professor Linnemeyer Hein for her excellent talk and her presence here in the afternoon. We're also going to thank Greco as our sponsor of our webinar series. And then lastly, I would like to thank the attendees for their attention, and please find this on YouTube. Okay, bye-bye.
Bye.
Bye-bye.